won't have it on the test on Monday.
We already have tests on Monday?
Yeah, we're having a test on Monday.
So today review day?
That's what's on my syllabus.
Man, this is sneaking up on us.
I know, yeah. So, what is today? Today is the 10th? No, the 9th? Yeah, we're supposed to have a test on Monday. Okay, so I'll get that going. So let's go ahead and review a little bit for the test. And I'm not going to make it tricky because a lot of these symptoms on the liver cancers and stuff, the liver pathologies, they're all so much alike that they kind of overlap a little bit, a lot really.
Yeah.
Because they're all going to have basically the same symptoms.
Fever, abdomen pain, hepatocellular.
So, I'm looking at my book. Hang on. Okay, so pathology starts on page 130. Begins on page 130. So you need to know what hepatomegaly is. And what can cause it. You need to know what fatty infiltration is and what causes that and what it looks like on sonography. Also, some of the things that cause like the two main causes are going to be alcohol abuse and obesity. Okay, so fatty infiltration, it looks a lot like glycogen storage disease. Glycogen storage disease, you need to know that that's hereditary. Of course, you need to know what it looks like. You need to know the difference between fatty infiltration and focal fatty sparing. This is infiltration. This is fatty sparing. Anytime you see either one of these disease processes, then you want to measure it and put color on it. That type 1 is an autosomal recessive disorder, glycogen storage disease. And von Gerkel's is the most common. It is a genetic disease, and as long as they go through early treatment, then they can live until adulthood. Type 2 is Pompe, and those babies usually die within the first year of life. Oh, I made tea, but I haven't made it up. Do you see it? Okay. Here is glycogen storage disease along with a liver cell adenoma. A liver cell adenoma is a non-cancerous tumor, but they usually like to treat it because it can turn malignant. It's linked to birth control pills. Hepatitis. Need to know that hepatitis is inflammation of the liver. Hepatitis A, you get it from fecal oral transmission, and it's very, very contagious. Hepatitis B is when a person comes in contact with blood or bodily fluids. That's the one that you can get a vaccine for. Hepatitis C, it's blood-to-blood contact. It goes all the way up to E, but our main concerns are A, B, and C. As far as sonography. You can have alcoholic hepatitis, and you can have non-alcoholic hepatitis. You need to know what hepatitis looks like. As far as the starry sky sign. Hepatitis can turn into cirrhosis. It's hard for us to see the veins with hepatitis. The portal veins become very hyper. That's what causes the starry sky. Elastography is good for hepatitis because it tells us how fibrotic the liver is. Okay. So here's an image of hepatitis. This is acute. Acute, the liver is going to be very hypoechoic. They've changed this with, they've turned up the overall gain so we can see the texture of the liver. Sorry.
Excuse me?
Yes.
A starry night sign, you mean it's because the edema change or because the increased the delineation of the portal triad?
It's because of the portal triad. The portal walls become more echogenic.
Okay.
Here we have acute hepatitis, and the vessels make linear bands extending to the periphery of the liver. Cirrhosis. Cirrhosis is where the liver becomes very, very fibrotic. And the nodules will, they can regenerate themselves. Glissen's capsule becomes very undulated. With cirrhosis, it's very hard for us to see the veins. It's very easy for us to see the portal system. Cirrhosis can also cause portal hypertension. Portal hypertension for us is a measurement of the portal vein that measures greater than 1.3
centimeter.
in a large liver. Cirrhosis can lead to liver failure. When you have someone for cirrhosis, you always want to look at the lung and the liver at the same time. A lot of these patients will also have pleural fluid, and you do need one of those before you graduate.
So you can watch it if on the order they say cirrhosis, right, Miss Sefer?
A lot of times they'll say follow up on cirrhosis.
Oh, okay.
But you should be able to tell if a patient has cirrhosis or not by now, because the liver will become very small, very undulated. It's hard for you to see any of the vessels inside of it.
But you still can see the portal system?
Yeah, sometimes.
Oh, okay.
Most times. Because it's going to be dilated.
What about for hepatitis, Ms. Shepherd? Is the portal vein visible for hepatitis?
Yes, you're going to have the starry sky with hepatitis. Okay, that in sonography, that is our sonographic sign for hepatitis, is a starry sky. For cirrhosis, it's an undulated Glisson's capsule and a small liver, a hyperechoic liver. Glycogen storage disease is going to be a very large liver, hyperechoic liver also. With cirrhosis, you could have increased, you'll have increased LFTs. Portal hypertension, y'all know what that is. Splenomegaly, y'all know what that is. Varices. Varices are veins that are large and swollen. Collaterals are a different pathway to an organ. Ascites, y'all knew what that is. Hepatofugal and hepatopedal, make sure you know the differences between that. Set alarm 11:45.
Okay. I set an alarm for 11:45 a.m.
Okay?
Can you give me a hug?
When you have cirrhosis and you have portal hypertension, your portal vein will not have normal portal flow.
Okay.
I'm not going to ask you anything about these. This is, if I have cirrhosis and I have collaterals, these are the different ways for collaterals to get to the liver.
Ms. Shepherd,
Yes.
earlier you said hepatitis can come from alcohol consumption.
Yes.
Is that hepatitis or cirrhosis?
Oh, yes, that is right. That's cirrhosis, not hepatitis.
Thank you.
Hepatitis, if you drink after someone, you can get it.
Okay.
That would be hepatitis A. That was my mistake. Sorry. So here we have cirrhosis. We have a small hyperechoic fibrotic liver. We don't see any of the hepatic veins. We see a little bit of the portal system, and you can see this falciform ligament. Inside the falciform ligament, you have the ligamentum teres, which is a remnant of the umbilical vein. That can recanalize with cirrhosis. You can follow it. It'll be, when you put color on it, it'll have blood on it, blood in it. And you can follow it right underneath the skin to the belly button. So here is a very small liver with ascites. Here you have some nodules that are seen. They almost look like bullseye, right?
Mm-hmm.
Because of hypo with hyper in the middle. It says here that it's regenerating nodules. Regenerating means it's trying to heal itself. So this here looks just like this here. Okay? But this patient had an elevation of AFP, cirrhosis. They did a biopsy, and it was HCC, hepatocellular carcinoma. Here they're showing you how to use the linear probe.
Capsule.
So that way you can look at Glissen's capsule. This one, the capsule is very, very straight. And in this one, you have a little bit of an undulation. You've got one here, you've got one here, and you've got one here. This is a sign. This is how we make a diagnosis of cirrhosis. This one for sure is cirrhosis. You can definitely see the undulation of Glissen's capsule. Color Doppler. Here you have the hepatic artery. It's very tortuous. They've got the color gain up too high. There's two ways that you can fix that. You can come down and go up in your scale, or go down in your overall color gain.
That hepatic artery, is that a cause of varices, the torsion of it?
Intrahepatic, I don't know the answer to that one, Pat. Sorry.
No problem.
It does look like it's dilated, because normally we have a hard time seeing the hepatic artery, though. So possibly could be. This is what the hepatic artery usually looks like. It's nice and thin and linear. And you can see here that the main portal vein is hepatofugal. When we do these Doppler signals, we have to make sure that everything is right, that we're not flipping the pulse wave, and we're not flipping the color. Here is an enlarged spleen. Here are esophageal varices. A little bit of ascites up here. Here is the ligamentum teres. You'll see it between the medial and lateral lobes of the left liver. And you can follow it all the way to the umbilicus.
Except for the
Yes.
spleen, for how many centimeter is considered splenomegaly? Big spleen?
How big is the spleen?
Yeah.
I'm thinking it's 13, but I'm not for sure.
13?
We can look it up real fast. I'm thinking it's 13.
I think it's 13.
So it's 1.2 and 13.
Let me look. Spleen. $235, $239.
To 14 centimeters.
Is it 14?
12 to 14. It's 12 to 14 centimeter. Got it.
Is that normal? Normal spleen?
Yes, normal.
Because it said that it can get up to 29, 30 centimeters.
So that's abnormal.
Yeah, that's definitely abnormal.
Yeah.
Thanks for looking that up.
So it's more than 13 is abnormal.
Okay, so this is the falciform ligament. The falciform ligament is the between the medial and lateral left lobes. Inside the falciform ligament, you have the ligamentum teres, and that is the remnant of the recanalized umbilical vein. It's also called the round ligament. That's two kinds of T. Okay. Okay. Here it's you can see it running right underneath the skin. Normal. Bud Chiari. Need to know what Bud Chiari is? Bud Chiari is a thrombus in the hepatic veins, and at least two of them for it to be significant. But if you find it in one, we do call it Bud Chiari. Sometimes you'll see hepatic vein thrombus along with IVC thrombus. Those people usually have ascites, hepatomegaly, and abdominal pain. They'll also have abdominal pain, jaundice, ascites, hepatomegaly, and splenomegaly. But if it's acute, you have ascites, hepatomegaly, and abdominal pain. So now on, when you take that IVC picture of the left lobe of the liver, you place it up to make sure you don't see any type of a thrombus. It is linked to birth control pills, tumor invasion from hepatocellular carcinoma, renal cell carcinoma, adrenal carcinoma, severe liver mets, and Wilms tumor. Wilms tumor is called a nephroblastoma. It only happens in our pediatrics. This is why it's important that we don't overcompensate our color, because you don't want to bleed outside of the vessels. If you can't find the hepatic veins with regular grayscale and color, use your power color. Don't move your hand and switch it over to regular color. That way you can get your waveforms on the hepatic veins. Power color is not directional. Regular color is directional. You have to have directional color for the hepatic veins. A normal hepatic vein is hepatofugal because it's leaving the liver and it's going to the IVC. But Chiari, because the liver can't drain the way that it should, everything's going to back up into the portal vein and the spleen.
A flow disturbance.
Yes. Also, if you have a thrombus in your IVC, then you're going to also have leg swelling, leg edema, because the blood can't get out of the legs to get back up to the heart. So you'll have edema. If your patient is in, what do you call it?
Heart failure?
Has to do congestive heart failure. That can also cause the hepatic veins to enlarge along with the IVC. Because remember, the SVC and the IVC dump into the right atrium. So if there's something wrong with the tricuspid valve, say I have regurgitation, then blood's not going to be traveling through the heart like it should. From the right atrium, it goes to the right ventricle, and from the right ventricle, it goes into the lungs. So if I have COPD, I'll also have problems. The portal vein is usually very monophasic. If it's not monophasic, or we have flow reversal, it could be because of tricuspid regurgitation. The tricuspid valve isn't working the way that it should. Here is the Canadian moose sign. Here is your IVC, your right portal, right hepatic vein, your middle hepatic vein, and your left hepatic vein. And you can see that the IVC has a W waveform. That is our sonographic sign for congestive heart failure. In picture C, we're taking a picture of the portal vein. And you can see, because it's blue, it's hepatofugal flow. Hepatic cysts are either congenital
acquired.
polycystic liver disease, or it could be caused from I can't remember what that name, Caroli's disease, that has to do with the ducts inside the liver. It increases with age. Also, if you have PKD, adult dominant polycystic kidney disease, then it's not unusual for you to develop cysts in the liver, the pancreas, the spleen, the ovaries. Acquired cysts are either trauma, parasites, or some type of an infection. Congenital cysts may elevate your LFTs, may not. If they get large, of course, it's going to cause hepatomegaly. They're usually going to be an incidental finding in the right lobe more than the left lobe. They can do contrast enhanced ultrasound to differentiate a complicated cyst from a malignant process. A cyst is a cyst, 3 criteria: smooth borders, anechoic, posterior enhancement. When you are imaging, make sure that you try to get rid of reverberation artifact, because you don't want that to be a diagnosis of a complex cyst. Here is polycystic liver disease. Here is polycystic liver disease along with polycystic kidneys. We can't tell the difference, okay? But if we have a PKD patient, they usually come in once a year for follow-up. You never take a picture of just the kidneys if a renal is ordered. You also want to do a sagittal and transverse of the liver and a sagittal and transverse of the spleen. Because when you take those images, you're telling the doctor, I looked and I didn't see anything. Acquired cyst, it could be a hematoma, which has blood in it, a biloma that has bile in it, an abscess, which has pus and gas in it sometimes. Gas is a bad sign. Econococcal, that's going to be a parasite. There are several classifications for acquired hematoma. Contusion, subcapsular hematoma, a laceration, and a transcapsular laceration that has a rupture of Glissen's capsule. A bleed can be significant for a person going into shock. And shock is a decreased
blood pressure,
decreased in blood pressure,
heart rate,
a decrease in heart rate, and a decrease in hematocrit. When a person comes in from a car wreck, they routinely do a peritoneal lavage. And if it is positive for blood, they immediately take them to surgery. It can also be caused from an interventional procedure, an aneurysm of the hepatic artery, or pregnancy-induced hypertension. The liver will be very, very tender. A parasitic tapeworm. A parasitic tapeworm also has daughter cyst. They can be unilocular looking cysts, or they can be varying sizes of multiple cysts. Our sonographic sign is a daughter cyst. It looks like a honeycomb. If it's old, it could have calcifications around it.
Shaptation.
Here is a post biopsy, and you can see that it's isoechoic, so it is fresh blood. Here it is 4 hours later. The blood cells have already broken down, and now that this area, along with this one septation, is hypoechoic or anechoic almost. Acquired cysts. These on biopsy were biliomas. A cyst full of bile. This is an coccal cyst.
Tapeworm.
And you can see that there are daughter cysts.